Sure, sure. Good evening, everyone. I welcome you all for the What is Expertise session. And today we have an interesting talk on autism with Dr. Tuba Rashid Khan. I would request our President Shafali ma'am to introduce the speaker for today, the moderator and expert for today's session. Over to you, ma'am.
Thanks. Welcome you back to the AOCN series. And today we are going to be having a talk based on the growing child with autism. And the speaker today, Asmita, can I have the slides? The CV slides is Dr. Tuba Rashid Khan. She's an international leader in pediatric neurology and autism care at the Autism Spectrum Center, Boston Children's Hospital, Harvard Medical School, and former medical director of the neurodevelopmental program at the Emory University, and associate program director, neurodevelopmental disabilities program, Boston Children's Hospital. She's done MPH and MEd in addition to her MBBS, and she has been recipient of multiple awards, including the Futures in Neurology Research Award of the AN, A.B. Baker Teacher Recognition Award, and the Pella to See Advocate Award of the AN, and has written a book, My Friend Adam, which is an inspiring children's book. And she has made a lot of global impact with innovative autism care and neurodevelopmental disorders and pioneering transition care models and leading community engagement, advocacy, and education initiatives. Thanks, Dr. Tuba, to have joined. And our experts for today are Dr. Susan Kus from Ege University, Faculty of Medicine, Child and Adolescent Psychiatry Department. And she areas of interest include autism spectrum disorders and neurodevelopmental disorders, and early diagnosis, and also the transitional through adulthood, and has 82 publications, index in code WS, and total 111 publications, and has completed 9 research projects and lots of awards. Thanks, Dr. Session. Then we have our friend, Dr. Farida Jan, Associate Professor in Department of Neuroscience and Neurorehabilitation in Sindh Institute of Child Health and Neonatology from the Likat National Hospital in South City Hospital, Pakistan. And she has done her FCPS in pediatric neurology in addition to other degrees, and her areas of interest include neurobehavioral disorders in addition to lots of hardcore pediatric neurology areas, and has many publications and has been a pioneering member of the Child Neuro Society of Pakistan. And thank you, Dr. Farida. And we have Professor Paul Russell, who is a senior professor in Facility for Children and Neurodevelopment Disabilities and Child and Adolescent Psychiatry Unit. And he was formerly the head of the facility in CMC Vellore and has been the head of psychiatry in CMC Vellore. He has 167 international publications and a lot of a lot of them are on neurodevelopmental disorders, has got the doctorate, the coveted doctorate of Doctor of Science for the lifetime work on children with adolescent and neurodevelopmental disorders from the Kerala University of Health Sciences. Also the many more awards like Nilofer and India Clin Best Young Scientist Award and Ruth Shako Award. So he's very celebrated pediatric neurologist. And another dear friend, Professor Maya Thomas, who is a well-renowned and admired professional par excellence, professor and head of pediatric neurology in CMC Vellore, Tamil Nadu. She has autism is an area of interest in addition to epilepsy and many other areas. Our moderator for today is Dr. who is our alumnus he did his DM Pediatric Neurology with us, and he's consultant pediatric neurologist, Zydus Hospitals, Ahmedabad, an honorary consultant and faculty in the postgraduate pediatric neurology fellowship from the LG Hospital and Medical College, Ahmedabad. He has more than 24 publications and is a reviewer for BMC neurology, and area of interest besides hardcore areas of pediatric neurology is also neurobehavioral disorders, and as got lots of awards as well. Harsh, it's all yours.
Thank you so much, ma'am, for the kind introduction. So now without wasting time, I invite our lead speaker, Dr. Tuba Rashid Khan, to deliver her very much awaited talk. Over to you, ma'am.
Okay, thanks. Can you see my slides?
Yes, it is visible.
Okay, wonderful. Okay. Everybody, thank you for attending. I see there's almost more than 100 participants, and it's an honor that you're giving me your precious time. And it's an honor to share the floor, virtually speaking, with so many advocates who care about kids across the world with neurodevelopmental disabilities. So today we're going to talk about the growing childhood autism. We're not just going to touch base on the scientific aspects that lead to the developmental divergence, but also some of the things that are really important to consider, not just from a medical standpoint, but the things that make them vulnerable and how to support them in that vulnerability so they're not as risk for certain things that create more trauma in their lives. And then really providing a voice across each stage of their journey. Okay, this is the true test. Did you see the second slide? Has it changed? Okay, I see a nod. Okay, great. So autism spectrum disorder, it's a neurodevelopmental condition characterized really in challenges in communication, social interaction, and behavior. A lot of times I'm asked, well, this person is a bit odd. Not that I like using the word odd. And, oh, this person is a bit quirky. You can be quirky. That's beautiful. You can have a different way of viewing things, but this is a disorder. You need to have challenges. And these challenges, if they're unmet with the proper therapeutic interventions, then it's going to lead to even more challenges. And that's really the crux of what autism spectrum disorder is. It presents widely. It's not just a box here and here and here. It's really a line that goes on and involves atypical patterns of expression, processing, and how individuals interact with the world. I sometimes give this analogy that your child is amazing, but it's like they're in another country where they don't understand the culture, the language. They're trying to get through to you, but it's a completely different world that they see, hence the challenges that come. You know, we kind of started entering the DSM-5 world around 2013, and then in 2022, we made the verbiage better and more easily understandable, hopefully to our clinicians around 2022. And really, you need to have core deficits in all three areas in the A part. So deficits in social emotional reciprocity. And this changes at each age level, right? From like 2 to 4 years of age, the play skills, they become more mature, more interactive, more to and fro. How you communicate with your parents is with more mature gesturing, more appropriate use of phrases. And then the deficits in nonverbal communicative behaviors, we're using a lot more nodding, a lot more yeses, and obviously for young kids, the importance of the no. And then deficits in developing, maintaining, and understanding relationships is one thing where the parent is always filling in the gaps to support their child, but how much can the child also give back in maintaining and understanding that part, whether it's to peers, families, and teachers. For the B part, you only need 2 out of 4. So is there stereotypies, motor stereotypies, vocal stereotypies, the way of rhythmic, repetitive use of atypicality when it comes to object use, and insistence and inflexibility to routines. You know, some of us are pretty inflexible in our routines too. I like my coffee a certain way, but am I going to have a tantrum? Am I going to fall on the floor and say, I'm not going to go to clinic? No. So anything that really leads to challenges, burden in the inability to thrive is what constitutes a disorder. Highly fixated interests, right? I'm interested in medicine, but let's say if my husband comes and says, hey, it's time to go for dinner. I mean, sometimes I do procrastinate it, but we get things going, right? And so it could be that there's such a fixated interest, they're looking at that train, but they're going to forget about eating food, right? And the parent really has a hard time with that shifting of transition. And then hypo and hyperreactivity to sensory output and input. It doesn't have to be too much. It can also be too little, right? Some kids, they don't want to wear certain textures of clothes. They have aversion to water, which can really affect hygiene matters. Symptoms must be present in early developmental period. I know there's controversy around it, especially as there's more awareness with adult autism diagnoses. But really, if you're a good historian and you peel back the layers, you'll find out there were challenges that were fallen through the cracks when they were younger. Again, we hone into this, right? There's significant impairment in the ability to thrive in one or more areas of their life. And then even though a child can have autism and associated intellectual disability and other neurodevelopmental disorders, it has to be more than that. It cannot just be solely explained by, per se, if a child has intellectual disability. Is the social communication deficits over and much more challenging than one would expect with a child with this certain level of intellectual disability or speech delay. For example, when PCPs, our primary care physicians and docs, ask us, well, this child has speech delay. What happens with someone who has a speech delay as they grow older? They're gonna compensate with use of verbal away overtures, right? So if someone has a speech delay, they're going to use their hands and gesture more. If we go to a country where we don't know the language, what do we typically do? We'll say, where is the train station, right? So if it's one thing that's a specific delay and the child is thriving well and has no other disorders, you will likely see an overcompensation of other ways to communicate that take place. Let's talk about the brain networks in autism spectrum disorder. The interesting thing is, right now we're talking about this in 10 years. The exciting thing about pediatric neurologies, we're going to learn more and more and more. But the beautiful thing about learning more and more and more is we're not finding siloed spaces of networking. We're finding more and more integrated uses of why something happens, and it really explains very nicely why it's a spectrum of multiple symptoms versus just one thing that's related to one area in the brain. These networks can affect social cognition, sensory regulation, and executive functioning. So you can really, in your mind, understand it as a developmental disconnection syndrome. That's why kids with challenges in social communication, wherever they lie on the spectrum, you will more typically hear from parents, oh, but he or she understands more than they can relay. And you also see in clinic, they sometimes follow a little bit more instructions than they can express themselves. And there's really this disconnection of the bridge between this understanding and communicating with the world through our different ways of doing it. We're learning that it's really an under pruning that leads to inefficiency, right? The older we get in our careers, we're going to get great, hopefully, in our areas of expertise. But as we do, we kind of forget the things that are not necessary to our patient care that we learned 20, 30 years ago. Pruning is a really important factor in becoming efficient, in becoming an expert in what you want to pursue. So the key brain regions are the medial prefrontal cortex, the superior temporal sulcus, the amygdala, the fusiform face area. And really, when you talk about the fusiform face area, it really makes sense, right? This gap in understanding how to have this to and fro reciprocity, this inefficiency in joint attention. And even though not all kids with autism have poor eye contact, this could be an area where you have those triggering behaviors when it comes to unsustained eye contact. Since I talked about the eye contact, where now we're moving towards a path where a child with unsustained eye contact is not a necessary criteria for autism spectrum disorder. It's about maladaptation, right? It's about deficits, it's about challenges. So you could have a child or a teenager with autism make too much eye contact where it's uncomfortable, right? That's a understanding challenge in what makes appropriate social communication through nonverbal gestures. Then your sensory motor integration, right? Again, beautifully explains why these kids can have sensory issues. There's issues that have been found in the networks in the thalamus. Now, I do want to take a pause here, right? We're learning this all through histological data, fMRIs, but a lot of times when there's no other focal neurological deficits on the neurological exam and we get MRIs on these kids, it looks normal, right? It's a picture, but there's so many things happening behind that picture and like neuronal synapses and connectivity. I'm going to save the cerebellum for the last part because I love the cerebellum and it plays an important role in autism and cognition. And we're going to come back to that at the end. So in terms of sensory motor integration, we know insular cortex plays such a marvelous role in that. And then there's this default mode network, right? That's the great thing about the brain. Something's having a challenge, the brain starts creating pathways in another way. That's why overcompensation is one of the hallmarks of a resilient brain. And then the default mode network can also occur back to the medial prefrontal cortex. That's why you have that fixated interests part. And then you have the inferior parietal lobule also involved. Okay, let's come back to the cerebellum. I'm going to take a sip because this is going to be something that's my fixated interest. So 12 years, 15 years ago, the overarching thought was the cerebellum controls fine motor movements, right? Issues in it is going to lead to dysmetria, ataxia, and in coordination difficulties. But it's not just a theory anymore. We have so much evidence and data now that the cerebellum is not just this isolated controlling master of our body's fine motor movements, it plays a huge role in cognition. And it makes sense now. When you have a child with Fragile X and they have that uncle who had the CGG repeats that was between 50 to 200, so not meeting the Fragile X definition, but still enough abnormal amount of repetitions to see clinical symptoms, right? Now we call it Fragile Ataxia Tremor Syndrome. Ataxia Tremor Syndrome. Now it makes sense why CGG doesn't just lead to autism when there's abnormal repeats, why it just doesn't lead to cognition issues and developmental delays, but also the ataxia and tremor. So you have this triad of where the cerebellum controls so much more than fine motor movements, cognition as well. The same thing we see in our kids who have spinocerebellar syndromes. And so never underestimate the power of the cerebellum. You know, they've done studies, autopsy studies where they saw volume changes in patients with autism when it came to the cerebellum. Okay, so this is a nice diagram for people who are more visual learners than auditory learners, really kind of talking about the pathways that are important, right? It's not just one path that diverts off. You really have these different areas where you have these interconnectivity maladaptations happen, and then other areas kind of take over to the default mode. Okay, so key concepts to remember. There is issues with connectivity between different areas and circuits, and the frontal part and temporal parts may explain those social communication difficulties. 10 years from now, you'll have someone else who's a leader in the field, maybe adding 2-3 more lines to that. You just don't have hypoconnectivity, right? You have those default modes. And so then there's an overconnectivity kind of leading to that whole underpruning we were talking about earlier, that really is suspected to play a role in the rigidity and the stereotypies we see. And, you know, functional brain imaging is something that really is giving us a lot of data, and especially in early development. And a lot of institutions worldwide are having a lot of, you know, interest in this area of research. So go on, researchers. I'm excited to see how we learn more. Okay, now neurotransmitters. This is going to take another sip of water too. This is really important because 20 years ago, believe it or not, there was this controversy that if someone had autism, they could not have ADHD. If someone had ADHD, they could not have autism. And there was this boxes of diagnoses. But now we know it's kind of like an iceberg, right? If you, and my favorite thing to draw for our med students is like a Venn diagram, right? You have a little bit of autistic features, you have a little bit of ADHD features. Some of these symptoms are shared in that Venn diagram. And then if you have significant amount of hyperactivity or inattention that's stopping you from thriving, then your ADHD plays a stronger role than your autistic features. And it could be you don't have that many ADHD symptoms to classify an associated diagnosis of ADHD with autism, right? But this neurotransmitter data explains why someone with autism is at risk for epilepsy. Someone with autism is at risk for ADHD, depression, anxiety, OCD, because it's all these neurotransmitters and the issues and challenges in them that lead to these disorders, all the way from autism, ADHD, and anxiety. So GABA. It's interesting. One of our Grand Round speakers 2 weeks ago was talking about GABA and its role in arginase deficiency and OTCs and the urea cycle disorders. But we'll come back to autism. So GABA is a major inhibitory neurotransmitter. So the reduction in this, it leads to sensory dysregulation and seizures. Now, not every kid with autism has seizures, but they are at risk, right? And it also explains why we have anti-seizure medications that play a role through the GABA pathways. And it's really this seesaw of issues and excitatory mechanisms and inhibitory mechanisms, right? And that's the same thing that applies in all neurological conditions, whether we go outside the pediatric field and it's about Parkinsonism or Alzheimer's. The next thing is glutamate. So this is your excitatory neurotransmitter, and it may be what can explain that cortical hyperactivity associated with emotional lability and stereotypies. And then, yes, the serotonin. Who doesn't love serotonin, right? Makes us happy, makes us calm. Some of our foods are serotonin we love. So, you know, it's been seen that there is elevated peripheral serotonin in 30% of autistic individuals. So too little and too much of a thing is not great, right? It's about the balance, and it's about the efficiency and how things in the brain are functioning to come together to help this child thrive. It impacts mood, it impacts sleep, it impacts sensory sensitivity. For people who are like, how does it impact sleep? Well, a lot of antidepressants and anti-anxiety agents, if the patients take them later at night, it can disrupt sleep, right? Because at the end of the day, it's an activator. And then the role in early brain development and social behavior modulation plays an interesting role. Okay, so again, for our visual learners, this is the other neurotransmitters that are gaining track. Stanford is doing some research on oxytocin, and some of my parents in the last year have been asking me, Doc, tell me about this oxytocin, what's happening? So we'll go into it in a little bit. Okay, so this is a nice summary table. If anyone wants to take a picture, it kind of really gets to the significant points. So GABA is for inhibition and glutamate is for excitation. And when I mean inhibition and excitation, I'm not talking literally how the body manifests this. I'm talking about the inhibitory pathways that are activated in the brain, the excitatory pathways that are excited in the brain, right? And so I went into details for the first three. Let's go a little bit down in the last three. So dopamine. We have 2 FDA medications in the autism world, Risperdal and Abilify. I'm hoping in the next 5 years we have more meds. We need to catch up with our epilepsy friends who have now more than 30 anti-seizure medications. Okay, so Abilify and Risperdal, they both activate and have a role in how they're going to play with that excitatory inhibitory pathway and receptor control with dopamines, right? One is partial, one affects the D2 receptors. So it can really help with behavioral dysregulation. And then for neurotypicality, it really is the thing in the basal ganglia that creates and breaks habits, the dopamine release in terms of reward, attention. The oxytocin, again, is relatively new. They found the research they're doing is that in some participants, and the research is not in the young children. Some of Stanford's latest studies, they were doing it in kind of the middle school aged kids, which is interesting, but they saw some data where when they were giving oxytocin to these kids, it was increasing their empathy and their social emotional reciprocity. It wasn't curing them out of their autism, but they saw some improvements. Again, there's still much more to do in this research. So I had this case come to clinic, and this mom was just so sweet, and she was like, Dr. Rashid Khan, I never breastfed breastfed my kid and I saw this research that moms who breastfeed their kids, there's oxytocin release. Do you think my child has autism because I didn't breastfeed them? And I was like, no, 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 no. We have kids who are not breastfed and don't have autism, and we have kids who are breastfed and have autism. That's not a clear correlation. The same thing when it comes to an SVD delivery and a C-section, right? Because we know with SVD, there's more oxytocin release versus a C-section. And same thing, there's not any strong correlation that the way the child entered the world is the cause of autism based on whether this was a spontaneous vaginal delivery versus a C-section. So I definitely reassured her that this was not me trying to make her feel better, but there is absolutely no data when it comes to that. And this is just the importance of neurotransmitters regulating the brain. And then acetylcholine, right? That also plays an important factor, not just in autism, but also ADHD, right? And it helps with sensory filtering, attention, and modulation. Okay, so brain networks formation begins early in gestation, right? It really starts forming by week 6 to 8. That's why we tell our moms, you know, those prenatal vitamins, that folic acid is really important in the beginning. And then we can see defaults starting to really formulate between 28 to 32 weeks. So that's really important data to share in a culture where the mom takes on so much of the guilt of what they could have done better in their pregnancy and afterwards to have prevented the autism. No, that's not the case. Women and moms need to stop blaming themselves. We now have data that supports it, right? And really these divergences and disruptions, they start happening in the prenatal development. And there's so many factors that affect these gestational events, right? It's multifactorial. It's your epigenetics. It could be inflammation. It could just be your gene changes that occur in terms of spontaneous mutations or inheritability. Okay. Let's see. Okay, perfect. My cursor is working. So early identification and intervention is super important, if not the most important thing in our autism world, because we know the brain has got the most neuroplasticity in the first 3 years. And, you know, it's not that kids aren't going to start developing if early intervention is not received in the first 3 years. Really, it's the first 5 years. And we know our frontal lobe doesn't completely mature till we're 24, and in some adults even later than that, right? Because not everyone follows their own boxed way of pattern development. Okay, so intervention is pertinent. And why? Because these critical years, right? And the thing is, sometimes it's easy for us as docs to be like, okay, ABA therapy, bye, applied behavioral analysis. But it's so much more, right? It's supporting the child, supporting the caregiver. If the caregiver is taught how to use tactics to support their child, then it's a multifactorial setting of thriving. If something's happening at the therapy place, but not being reciprocated and followed at home, the child's not gonna embed those ways of learning. And that's why across the globe, we have so many parent training tactics onto how to learn to use ABA and ways to use therapeutic interventions at home. But we always also want the parents to have fun with the kid, right? It can't feel like hard work at the therapy place and at home. Okay, I see a raised hand. Go ahead, Dr. Mergen. Do you want to say something?
Sorry for it. It's done by mistake.
Okay, we'll convert your raised hand to like, yes, you agree. So how do we get those interventions? If we believe interventions work, which I have never met a person who doesn't believe interventions help somewhat, what do we need? We need a good screener. We need good diagnosis, right? So a good screener is brief. It's not going to take 3 hours. right? That's the diagnostic test. That's what the diagnostic test is for. It's culturally responsive, right? And accessible. And that's why I want to go back to the eye contact. A lot of cultures, especially the cultures that a lot of our expert panels are from, right? It's considered rude to stare. A lot of parents will tell their kid, don't stare at the adult, it's rude. So that's why you have to look at the multitude of symptoms. You can't just say yes, no to one thing that doesn't apply in certain countries and certain cultures. But I love pointing, because you will go to any part of the world. And I can say this because I grew up in the Middle East. Like we talk a lot with our hands. In Italy, there's a lot of this, but you don't see a 2-year-old go, "Mama, I want milk," right? Wherever you are, it's beautiful. The pointing is always going to be there in a typical child, not this, but this, because the human brain has evolved. Where if I do this, it's a little finger, no one's going to see it. If I do this, people are going to see it. And so really hone into social communication, kind of the things that meet the DSM-5 criteria. And we use the MCHAT over here, and only 56% of kids who screen positive in America end up getting referred. And maybe more education will get those numbers higher. And still, the median age of diagnosis is over 4 years, but at least now it's not over like 5 years. Okay, so this slide is something I presented last year, so I'm going to go over it briefly. You don't have to wait till 2 years to diagnose a child, right? We see a social smile before 6 months of age, right? For a typical kid, we'll see a social smile, giggling, purposeful eye tracking towards parents, all within the first year of life. So really, the screening tools should be implemented at 9 months, and then per AP guidelines, which is our American Academy of Pediatrics, at 18 months and 30 months, as well as the 9 months. And then in some guidelines, you'll see 12 and 24. But if you notice something, there should be no delay. Don't be like, oh yeah, that guideline said 24 months. No, you see something, screen, because we got to get that early intervention at the high neuroplasticity time. And then, it's easy for the kids that screen in the high numbers. But so for the MCHAT greater than 8 or equal to 8, it means high risk. But the kids who scored intermediate 3 to 7, they need to come back in 3 months. You can't delay the time and screen again. And they saw that kids that screened a second time for those intermediate scores, there was a 47% risk of autism being diagnosed and a 95% risk of being identified with some other type of neurodevelopmental issue. Okay, so autism diagnosis is clinical. That's why you need to have good clinical training, which I know Dr. Gulati has done great work in, and we're very grateful for that. And everyone who's attending here, thank you for always trying to be better for your patients. And here in America, we use the key diagnostic tools, the ADOS, the ADI. The ADOS has more structured PlayNet. The ADI has more caregiver interviews. The reason the CARS has the longer description is because I use CARS in my clinical settings. It's a structured clinician rating tool that scores on 15 observable behaviors. And some of the high functioning kids, it may not be that one time I did it. I'll call them again in a few months and do it again. And the nice thing is, in between that time, I ask parents to document and write down things that they feel are of concern. So a lot of times the parents are now prepared for that diagnosis and not shocked by it. They're like, actually, we think the child has it. I'm like, there you go. Okay. So for our visual learners, diagnosis is more than a checklist, right? You need to be a good developmental historian. You really need to respect the parent and what they're seeing. You need to have structured observation. If you can get enough observational data in the first try, especially if the child is scared, right? There are kids who are really scared of doctor visits. So a lot of the times what I've started doing is we have a good intake team that will talk to parents about fear of doctor visits. And so we'll have them sit in the waiting room. We'll bring a coloring paper. I'll sit with them on the baby desk and I'll color with them so that they don't view me as something as fear. It's really working well. And so then once we transition into the clinic room, for kids who don't have that severe transitional rigidity, I get more observational data. So sometimes it's nice to just be a kid and color with your patient before you take them and be a doctor. You know, genetic and medical evaluations are important. There's so much genetic data now that you can give parents. Not always the case. We still have a lot of variants of unknown significant clinical results that come. And then really a multidisciplinary team, talking to a psychologist, talking to the therapist as you support this family in their journey is really pertinent. So it's a spectrum, right? There are going to be multiple domain challenges in language, cognition, behavior, sensory. And the thing is, a child can be strong in one area, but profoundly challenged in another. And so that's why it's key to work and maybe touch base with the ABA therapist once in a while to be like, what is the issue right now? Right? Not every kid is going to have behavioral dysregulation as an issue. And so understanding that, okay, right now the challenge is in conversational reciprocity. Then you're recommending and writing a letter of advocacy to the school to implement more support in social skills and more social skills inclusionary classes. And so different, you know, some kids need help with self-care and hygiene. So you really need to understand as you are supporting this child in their journey, what are the areas that have now improved and what are the areas that are still of challenge. And so that's why ABA is not just ABA, right? And that's why some parents can sometimes have bad experiences with ABA because if the doctor and the therapist are not communicating, we can't help support them in the challenges at a specific age that that child is having at a specific time. So really modern ABA touches base on all of these things. And then we talked about IEPs, right? A doctor's visit is just a couple hours a year. School is where they spend most of the time. So that's the area we need to support them the most. We need to have more behavioral trained teachers and providers at school so they can nourish our kids in the time that they're growing. And you know, the early school years is really the building foundations, right? That's when they're starting to find possible friends and peer interactions. Middle school, it's a shifting landscape, right? Academic demands rise. And so this is where some of the kids who may have missed the diagnosis, now they're being referred to you because the social complexities are getting more difficult. Now classwork involves more team projects. So some of the kids with deficits in social emotional reciprocity and social communication that weren't huge deficits, but moderate to mild deficits, they might come to you at that stage. And really, you know, when a child doesn't have a diagnosis in middle school and they are not connecting with their peers, it's impossible for them to have zero anxiety. So when they're coming to you, not only do you have to look at it from a new diagnosis standpoint, but you also have to address how you can support them in that anxiety part. You know, increasing executive functional demands, it's hard. It's the reason people get tired. And there's this growing awareness of being different. So it's a time to introduce self-advocacy, you know. And in clinic, I'll practice. I'm like, just pretend I'm your teacher. What are you going to say? And then the child practices with me. Okay, I'm having a hard time. You're going too fast for me. And, you know, the child will like mimic raising his hand or her hand. There's masking, right? many kids who are on the higher functioning side, they tend to stay quiet. And then sometimes the teachers are like, oh, this is such a polite child, but they're not participating and they're not doing well in school. And then you can have autism, but be super smart and not have an intellectual disability. So you could be doing great at maths, you could be doing great at science, but now those team projects are coming in and you're not getting the grades you want in those team projects. And that's again adding to the fatigue, the anxiety, the identity confusion. And we talked about it, right? The quiet child is sometimes known as the well-behaved child, but that could be a sign of masking. Okay, so the role of the environment is really a key in those middle-aged and I mean, the role of environment is important for everyone at every stage, whether you're neurotypical or atypical. So it helps as a huge protective factor, predictable structure, visual cues, trained staff. These are all important to support kids in school. Your behavioral strategies and self-regulation and coping. That's why sometimes you have these kids come to you and they're saying, oh, they're oppositional, they're severely dysregulated. But you really have to peel back the layers. Are you dysregulated because you have the inability to understand and regulate your emotions? Or are you dysregulated because you are so overwhelmed, you don't have the right diagnosis, giving you the right interventions, and you are just fatigued where now everything is bubbling up? The other thing is, for kids, space is important, but it's not suffice. You just send the kid to the room, wait for them to come back. So some of the letters I write to school is, if the child prefers a sensory room, have them go in, give them a timer, because you don't want the kid to just be there till 1 hour and then the school bell rings and then parents are picking them up. They're gonna miss education, right? So give them a timer, 15 minutes, go back in, check on them. Don't force them to integrate back on the class, but definitely before they enter the class, you have to do a self-reflection exercise. How are you feeling now? What was your trigger? Not only that is that important in the child feeling heard, but that's important data for a doctor and a parent and a teacher to know, because then we can work with a behavioral plan. High school years. I mean, my kids getting bullied, it's younger and younger every year. And so that can really heighten anxiety, right? And every person is at risk of being bullied, I'm sure, of the 100+ participants, especially since we all are probably doctors and more on the studious, introverted side. We all probably have our own bullying stories, but we're talking about a vulnerable population that's at the highest risk to bully. And when you have social communication challenges, not only are you at risk of being bullied, sometimes you could be the bully. But I will say in my patient population, it's usually the first part, they're at risk for bullying. Depression, anxiety, suicidality, it's so important to touch base on suicidal thoughts, and you can't just let a patient leave without touching base on that. So your individualized education programs and plans, which is what IEPs stand for, it should also have mental health accommodations, a guidance counselor, for kids that aren't interacting. It's not just enough to be scolding the bully and saying, don't bully. Have supervised social skills inclusion groups where there's a facilitator, a teacher, nurturing that bond and breaking those patterns. And lunch bunches, we love our lunch bunches. I have some kids, they hide in the bathroom during lunch. And so we have teachers bring the child, sit with them on a lunch table, kind of make it a fun area where it's guided and they're being taught what are social appropriate behaviors. And not to forget, like, these kids are going to turn into adults. So helping them with independent life skills. So much of autism traits is, as they grow older in this journey, is the added social pressure, which leads to burnout. And our job as physicians is to support them before they reach that burnout you know, we're not just physicians, we're their advocates. We have to support them and talk to the school team about how you can make this environment more nourishing, more safe. You know, just the stats are in front of you. They're 3 to 4 times more likely to be bullied than their neurotypical peers. It can range from verbal to social isolation, that they're just going to ignore this kid, to physical bullying. You know, within the kids with autism, there's even a more vulnerable at-risk population, and it unfortunately is the minorities, right? Students of color, and people who, you know, race, gender, sex, they all make them more vulnerable, unfortunately. At Boston Children's, we have this amazing advocate, Dr. Peter Raffaelli. Dr. Gulati, if you ever want him to come and talk, let me know. He's wonderful. And so he's the medical director of the Boston Children's Anti-Bullying Support. And I'll refer some of my patients where those letters to school didn't work, and my meetings with the school fell on deaf ears, and they will have the screening tools, they'll have a social work, a behavioral health, all that have trained themselves to specifically be the best of the best advocates for kids undergoing bullying. And they will add to those individualized education programs through how to dictate the safe peer pairing that I talked about, and the sensory break access, and how to learn signs about passive bullying, right? Because teachers may not pick up on passive bullying. They're humans after all. They're taking care of 30 kids in one session. Okay, puberty, right? The hormones, they can heighten emotional reactivity. They can worsen meltdowns, anxiety. These shifts are happening without sufficient verbal and emotional tools in an already vulnerable population. But hopefully the slides we talked about before helps us be better in supporting them during puberty. It brings more expectations, right? More planning, more independence, more at home. At home, parents are expecting more, right? Help with the dishes. So as the social demands escalate, you know, people now want to romance. And so it's really important that now you start talking, if you haven't already, about social boundaries, privacies, autonomy, because the non-verbal kids and those with accompanying intellectual disability are at risk for abuse and exploitation. And so really teaching the child, or if they are really severe on the spectrum, teaching their team on how to create this safe atmosphere for them. You know, it's a nightmare, but we can't just scurry around and tiptoe around the topic. The numbers again are high, 70% of some form of interpersonal event that traumatized them. And, you know, sometimes the regression, the worsening behavior, it's not just puberty. You again have to peel down the layers and say, what's happening? What's changed? And develop that rapport with the kid, whether it's through the parent, the teacher, the psychologist, the psychiatrist, the therapist, and the doctor. We have another institution here in Boston, Boston Medical Center, and they're developing a risk assessment tool to identify what, you know, these kids. And so, you know, the dream would be every country in the world starts really understanding the necessity for this and how to make sure that they don't fall through the cracks. They're being identified and they're being placed in even more protective atmospheres, safe and nurturing. Not keeping them hidden in the room, but making them thrive, right? And if they can't self-advocate for themselves, then surrounding by the team that can support them. I have some kids that are going to college. In fact, I just got a message, and my nurse is here. She's one of the attending. So I got a message from one of my kids who just got into college. I can't say where because, you know, HIPAA protection, which I really follow. So things I'm going to do is I'm going to talk to the college guidance counselor. I'm going to ask to give her or him accommodations. Because, you know, they need an advisor to protect them at the dorm. And some of these kids don't want to have roommates. So we have, support systems where they can have that dorm by themselves so they don't feel socially overwhelmed. And then they need to have good peer mentoring programs in college too. And counseling is very powerful. Transition to adulthood. Autonomy, safety, support. These are important things. Even in a nonverbal kid, you have to advocate for them. And if full guardianship is necessary, the earlier, the better, so that these individuals with profound intellectual and safety challenges are supported. Many can thrive with supported decision-making, right? Like there are some kids, they may be able to go to college and get a job, but they need help with the bank accounts. That's where the parents need to be educated on supported decision-making. But then there's some kids where the parents have to take over, right? In many countries, once you reach a certain age, it's hard, right? It's hard for parents to access the kids' medical records and if legal rights. So you have to really start early, around 14, 15, 16, start preparing the parents that if this child needs full guardianship, these are the processes. AutismSpeaks.org, Boston Children's website, Autism Spectrum Center. There's a toolkit on the transitioning topics you need to address with the parents. And the AAP says that you need to start those transition talks even as young as 11 years of age. So just like we talked about, global adaptable planning, right? And in some cultures, you live with the family your whole life, and that's protective. But then what about the bank accounts, right? So you need to talk about all conversations and meaningful goals. Okay, I'll come back to this slide, but these are my references. And I will end with this. And thank you so much for having me. And I am ready for questions and additions.
Yeah, thank you so much, Dr. Tuba, for this very enlightening talk covering from neurotransmitters, from networks, and holistic overview of the entire holistic care of autistic children. I would like to invite experts for their comment.
Harsh,
Dr.
your
Kostik.
voice is echoing. You have two accounts open in the same room. Yeah. Comments, please. Comments from our experts.
Yeah.
Dr.
Fine.
Sejan, Dr. Farida, Professor Paul Russell, Professor Maya, your comments.
I can start. I want to thank to Dr. Tuba for her excellent and mentioning about every aspects of autism in his presentation. What can I say? What can I add? What can I emphasize? I think while I am listening, I want to emphasize that the heterogeneous but dynamic and developmental nature of autism and psychopathology, which I mean, as you mentioned in your presentation, the importance of environmental interactions, which can trigger the risks and or help the children. I think the environmental influences, environmental factors influence the developmental course. It is important to account for these issues, to my opinion. Autism is changing over time, as you mentioned. The needs of the cases and families differs over time. For very young children, maybe the diagnostic issues and planning the educational program is important. But during the school years, maybe the psychopathologies such as ADHD, anxiety disorders, peer relations, adjustment problems come into the picture. And during adolescence, they are also growing, and they have needs for independence. Self-sufficiency is important in adolescence. And also, as you mentioned, psychopathologies, depression, suicidal thoughts are important. So I want to emphasize that the developmental chronological evaluation of these children, when, why, which intervention they need. I want to add this to your presentation. That's all I can say. Thank you very much for your detailed presentation.
Thank you. It was indeed wonderful. Before the other experts say, I will just mention to our listeners that we will be having one of the pre-conference workshops is on autism, and Dr. Tuba would be there, as one of the experts for the workshop as well. Also, autism will be in the main conference as well. Yeah, Dr. Farida.
Thank you very much, Tuba. It was indeed a very wholesome and holistic presentation. So, echoing Dr. Suzanne, it covered almost all the areas. We sort of get fixated with younger children more because the younger ones are coming more to us in the clinics. But those children who have been with us over a period of time in the clinics, with them we find ourselves at a loss when, as you mentioned, when the puberty hits in girls and in boys, the parents are also at a loss. And then at a number of times we are also lost because less and less children, they appear at that age group to our clinics. So indeed, I feel very enlightened, especially regarding the links which you touched, the neurotransmitter links and the brain connectivity links. They were very pertinent, like they were just, the lost puzzles, the lost pieces of the puzzle. So thank you very much. At least for me, I don't think I was an expert here. I think I was made wise by an expert. Thank you very much.
Oh, you're too kind. Yeah, I mean, it feels like when you're diagnosing a child, that's it, and you are gonna just follow them as long as you can. But things and dynamics change, right? Over a few years, their autistic challenges may improve, but their ADHD worsens, or they didn't have ADHD symptoms, and now you have to circle back and see if they meet that diagnosis. Are they going to meet a diagnosis for generalized anxiety disorder or a specific anxiety? So, people sometimes underestimate the power of developmental behavioral pediatricians and think of it as like a simple journey compared to some of our more complex subspecialties. But true support means you're always keeping your eyes open and learning at each stage to support them the best way you can.
No doubt, no doubt. Completely agree.
Thank you for your kind words, both of you.
Paul.
Thank you. That was a clear lifespan kind of an approach to what you presented, and wonderful. I have some of the questions which can become a debate here also. One is, now we have autism in remission. So what are we dealing with? Are we loosening one end of the diagnosis who are not necessarily autism? Because the D criteria is not given so much of importance in the assessments now. So some of the children get tagged as autism and therefore they have a remission. Or are we talking about a true remission in the sense of the child is now having social communication, all the core symptoms that has really come down. So one of the things that is debatable is this autism in remission across the age groups. And secondly, should I stop or shall I continue, Dr. Harshan Patel?
Sir, please continue, sir.
Continue.
Please
And
continue.
the second thing is, what I understand is in India, there is about 1.8 to 2 million. That's a very conservative assessment of the children who need help. Now, I'm including also the adolescents. Now, in a Islamic country like India, we do not have a very organized parent-mediated therapy. Parent-mediated therapy is going to be for the long term, and 24/7 the parent is available for the child. Although evidenced and now pushed with so much of encouragement, the Lancet Commission for the parent-mediated therapies, India, and I see it, most of the low and middle-income countries do not have effective parent-mediated therapy program. And also the grief. I'm leaving the children now, coming to the grief of the parents. It is not a one-time kind of grief, but each time the neighboring child of the same age is able to achieve a milestone, the parents are in grief. So this is a very complex grief, unlike the other griefs where there is a loss of a loved one. Handling them is going to be quite a complex way to do that. And the self-injurious behavior. We expect children with low functioning autism continuing to have self-injurious behavior in the form of biting or knuckling their head, banging their head, which although doesn't kill very often, it produces a very visceral response in all those who see them. You have mentioned about the suicidality, which is very high with these children, but self-injurious behavior also should be taken into a serious consideration, and efforts should be taken to reduce that. Now, about the programs we have, now most of the programs in India are kind of adopted to suit the Indian situation. Still, many of the concepts and the conceptualization is from the West. So that is some area where the Southeast Asian countries need to progress. Now, about the policies, there are many countries with autism-specific statutes and national programs. They are good in paper, but reaching the ground level and be effective is another ball game. Probably that's going to take a long time for us to achieve. One of the positive things I read is that although RET has gone primarily mainly out of the umbrella of autism in a way, the drug torphinidine has come in and has cleared the phase 3 trials, and FDA has approved since 2023 for treatment of Rett syndrome. And therefore, probably there is another opening that's going to happen. Let's hope, amidst sometimes a pessimistic way of looking at autism, only sometimes with non-pharmacological methods, all the pharmacological methods are also going to make a break in, hopefully. Thank you so much.
So you raised all these beautiful points that are so integral. Did you want me to comment on them, or are you just leaving them to the air to ponder?
Would love to hear, but I would leave it to the chairperson to decide.
Anything you want to add, Tuba, you can, but if you think they are just comments you want to let go, then we can have Dr. Maya speak up, and then we can have quickly those 3 cases, and then the rest of the Q&A. You can even see if you can answer some in the chat directly. right?
Yeah,
Yes,
yeah.
yeah.
I think, for the self-injurious behaviors, those are the really harsh to see, right? And that's why when I talked about the neurotransmitters and how we only have 2 FDA-approved medications for behavior issues, even as severe as self-harm, Abilify and Risperdal, we really need more support for these families. I have kids on polypharmacy, and it has just become their way of communicating, right? To us, it's hard. And to these kids, it may be hard, but that's their way of communicating. And so reshaping those patterns and increasing it is important, but what do you do to the most profound? And that's why research is important. And that's why for some of these kids, they could be at polypharmacy and there's just minimal reduction. And so that, I agree, is something to ponder so that we all can sink in with it and the gravity of it and how to move forward. For taflunomide, it affects the IGF, right? And we have 3-4 physicians here that are using it. And they said it helps with some of the stereotypies, but there hasn't been significant data shifts in verbal capacity, in self-care capacity. So again, it's touch. It's a touch and a dot in the space of what we need to support these families that take care of the most profound. The third thing is in low resource settings, you may not have enough therapists, but you have dedicated parents. And that's why it's probably more sustainable to train parents than seek out therapists in low resource areas. And that's probably going to be the quicker win while we're coming up with, new gene therapies and new novel interventions. Okay, all yours.
I want to add, one has to remember the burden on the parents, and we have to understand because we analyze the data for about many of the moms. In a study, we found around 80% were clinically depressed. A psychiatric diagnostic. I'm not saying that it was feeling low, So I think it's important that I know we are also doing home-based interventions. We are making them understand, but I'm just thinking that what is happening in our countries, and LMICs like ours, is it's becoming mom-centric. It has to be
Yes.
family-centric. So the point is, it's
Exactly.
coming on one individual. So in that situation has to be kept in mind. Now I will request Professor Maya to make some comments, and then we have Harsh. We can have the cases very briefly as per the time, 7 minutes each. Professor Maya, please.
Thank you, Dr. Tuba, for that wonderful talk and all the expert comments. I want to highlight one thing. In addition to giving the label of autism using your various checklists, CARS, ADOS, I think it is important to do a etiology workup. Because it helps us to give us some clarity as to the long-term follow-up of these children and what to expect in the future, and also plan for any newer therapies in the horizon for these children. So I kind of very insistent about an etiology workup in children with autism. And as children with autism age, I think we tend to lean more on our child psychiatry team. As Dr. Russell has, we work very closely with them. We tend to lean more on them because I think they are much better with all this psychopharmacology than any pediatric neurologist. And we really need to, involve multiple disciplines for the overall and holistic treatment of these children. Thank you.
Yeah, thank you. So I'll end with 2 comments. So, when Dr. Gulati said the parental depression, they've done studies where they saw that the cortisol levels and the stress levels of parents with kids with special needs was similar to that of being in war. And a lot of the times the parents feel helpless. So when you support and empower the parents, you're taking a huge play in something that can be protective. The other thing is I cannot emphasize any more to what Dr. Maya said. You remember my slide? The wheel of every aspect has to be taken care. That's why developmental physicians, you can't just be one thing, right? There was a wheel that talked about medical and genetic evaluation, multidisciplinary support. It's a wheel that we have to keep on checking, and that's the best way we can advocate for our families. So thank you, everyone.
Thank you. And Harsh, you can call the first speaker while the slides are put. Just wanted to mention that what you were talking about the wheels is very important in our Indian situation. We had analyzed data of 1,872 children of autism spectrum disorder, and we found that 80% of them had comorbidities, and around 35% have more than one. So I mean that is something very important. So we have to holistically keep evaluating, and it's all dynamic. Things keep changing, and with what Professor Paul had said about remission thing, yeah, I will request Harsh to have and I'm requesting speakers to keep to that 5 minutes presentation and 2 minutes your moderator to make comments. Yeah.
Sure. So I invite our first case presentation, Dr. Merv from Turkey. Please go ahead with your case presentation. Yeah.
And Tuba, if any questions in the chat you think you can answer in the chat itself, then we can do, and rest we can just take immediately after this.
So I am sharing my screen. Can you see the slides?
Yes, it's visible. Yeah, please go ahead.
Okay. So it's a full screen, right?
And yes, it's working now.
Okay. Hi, I will present you a case with autism spectrum disorder accompanying with tuberous sclerosis complex. I would like to thank to my professors, Dr. Sezen Köse and Hasan Tekil, for giving me the opportunity to be a part of this organization. Autism spectrum is a common, highly heritable, heterogeneous neurodevelopmental disorder. It has core symptoms, as you can see here and mentioned before: social communication deficits, restricted interest, repetitive behaviors, insistence on sameness, and sensory sensitivities. The clinical presentation varying widely across individuals depending on cognitive ability, adaptive functioning, and environmental support. While some individuals with autism are nonverbal and highly dependent, others may display fluent language and considerable autonomy. Also, there are comorbid psychiatric and neurological conditions, as you can see here. They are common and can obscure core autistic features, complicating the diagnosis and delaying access to appropriate intervention. I'm going to present 15-year-old boy with tuberous sclerosis complex, autism spectrum disorder, ADHD, and anxiety disorder and depressive disorder. The first psychiatric admission occurred when the patient was 13 years old. Due to school refusal and inappropriate behaviors such as spitting at school, smearing faces on walls, pulling down his pants, and using profanity. He had difficulties in social interactions. He had obsessions, excessive interests on restricted subjects such as mosque, meteorology, construction, echolally inflexible pattern of behaviors, hypersensitivity to sounds and sights, these are autism symptoms. Also, irritability, impulsivity, aggressive behaviors toward his mother, and depressive mood was seen. Difficulties in selective and sustaining attention and academic problems, and his speech contents had themes of social anxiety. He was attended to the pediatric neurology outpatient clinic due to a tonic-clonic seizure at the age of 3. He diagnosed as tuberous sclerosis with brain MRI and genetic tests that revealed TSC1 mutation. Additionally, he was referred to a child and adolescent psychiatrist for the evaluation of comorbid neuropsychiatric disorders. However, the family did not attend psychiatric consultation during this period. As we know, scores higher than 13 points in autism spectrum screening questionnaire is associated with higher probability of autism spectrum disorder. It was 25 points in parent reports, 30 points in teacher reports. Also, scores higher than 19 points in child depression inventory is compatible with depressive disorder, which it was 24 points in child reports. Scores higher than 30 points in screen for child anxiety-related disorder is specific for anxiety disorder. In child report, it was 32 points. So, while the patient initially presented with symptoms of depressive and anxiety disorders, during the follow-up and detailed anamnesis revealed that he also primarily met DSM-5 criteria for autism spectrum disorder. Additional examinations are required for attention deficit and hyperactivity disorder, and also intellectual disability. Diagnosis could not be excluded because Whisker test was not completed. However, the fact that he reportedly acquired reading and writing skills at the expected age, it's less likely. During the follow-up, psychoeducation was provided. The treatment was initiated with risperidone and sertraline for anxiety and mood disorders. As no benefit was observed with sertraline, it was replaced with escitalopram. He began a special education program involving social, cognitive, emotional regulation, and academic needs. And while he refused to attend school, he was enrolled in an open education system. He generally preferred to be alone, and the father was not actively involved in the process. To deal the father's struggles accepting the diagnosis and involve the father to intervention process, family therapy sessions were planned. Psychotropic medications were beneficial. Improvements were noted in peer relationships, communication with his mother, and it was reduced anxiety and irritability and overall emotional stability. Tuberous sclerosis complex is an autosomal dominant neurocutaneous disorder that affects multiple organ systems. In addition to its multi-organ involvement, neuropsychiatric disorders are significantly prevalent, and we can imagine them as an umbrella term. These are autism spectrum disorder, attention deficit hyperactivity disorder, intellectual disability, and behavioral problems. Among these, autism spectrum disorder stands out as a particularly important comorbidity. As you can see here, 1/4 of tuberous sclerosis patients have autism, and half of them show mild autistic traits. 1 to 4% of patients with autism have tuberous sclerosis. You can see the genetic relationship in here. Early diagnosis and interventions are important because the brain is more flexible and adaptable compared to later ages. This flexibility increases the likelihood of long-term treatment success. So we can say that earlier is better. We need to approach a multisystemic disease multidisciplinarily. So all individuals with or suspected tuberous sclerosis should be screened with TANT checklist at the time of diagnosis and at least once a year. Here we see the TANT checklist. And also, child psychiatrists should evaluate all patients at key developmental stages. You can see the developmental stages in here. As a brief conclusion, tuberous sclerosis is mostly diagnosed in the early stages by pediatric neurologists. Early recognition and treatment of neuropsychiatric symptoms are crucial. Therefore, close collaboration of these specialties is essential. Thank you for your attention.
Thank you, Dr. Mao. I invite Dr. Susan for your comment. Yeah.
In this presentation, we want to share our experiences with an adolescent diagnosed with tuberous sclerosis complex, but who refused to admit to child psychiatry during adolescence period. But when he became at 13 years old, he admitted us with school refusal. While child psychiatrists evaluating school refusal, we should account the neurodevelopmental issues, and we saw that the autism spectrum disorder is the primary diagnosis. Also, he has, as we mentioned before, and Dr. Tuba's presentation, psychopathologies become prominent during adolescence. So he have to admit to child psychiatry, and we could diagnose him. And during diagnosis and after the diagnosis, we have difficulties with parents. We should share our experience. We want to share our experience about the parents in this presentation, because father didn't accept. His denial affect the child's treatment process. We refer them to family therapists. We deal with the mother's struggles with her husband and the child. We want to emphasize the multidisciplinary and multidimensional approach to autism spectrum disorder. Psychoeducation, parental therapy, child psychiatric therapy with child neurology, işbirliği. Yes, I want to add this to Merve's presentation. Thank you.
Thank you for a wonderful case. Thank you very much, Martin, and thank you very much, Dr. Sejan. I will ask Dr. Tuba. Dr. Tuba, can you just, we can have the slide, the certificate will mail to you, Dr. Martin. Any questions which we are there? Harsh, if you just want to read out fast, because then she has to leave. Dr. Tuba has patients waiting.
Sure.
So we can have those two cases. So you can just read up the question.
Yeah.
Meanwhile, Tuba will also think about the take-home messages. She's already typed 2 answers. We'll leave those 2 answers.
Mhm.
Yes?
Mhm.
Yeah.
Yeah,
Because she's
sure.
taken a lot
So,
of trouble and the big answer. So I think it's not okay
Yeah.
for
I know the
her
big,
to
big
keep on
questions, they
typing.
all require
Yeah,
their
yeah.
own presentation.
Yeah. So yeah,
Mm.
that's what. And we have those other 2 case presenters be ready. We come back to them, but she has a patient. That's why I was requesting that. Anyway, doesn't matter. But now we have to just finish off
So-
fast.
Yeah. So, few of the listeners has asked, what are the genetic takes would you recommend in autism children? And one also has asked, how do you deal with anxiety? And at what age will you sure that child is non-verbal? And what will you do when you find non-verbal autism?
Okay, that was a lot of questions in one goal. Let's do one
Yeah.
question at a time. So what was the first question?
Harsh, ask one question at a time.
Yeah, genetic test, what would you recommend in a patient of
Genetic
autism?
test.
Genetic
Yeah.
testing. Okay. So, a lot of the organizational guidelines is a chromosome microarray and Fragile X, right? But now we have this powerful tool that has almost what some research says is 99% more data finding, which is a whole exome sequencing. So if your country has the ability in providing these resources financially, then that's always the go-to. If you're seeing signs of hypotonia and increased appetite, and you're seeing signs similar to Angelman's and Prader-Willi, right? So these are your 15, Q11 to 13. There are specific tests for that. If you are seeing signs of Rett syndrome, MECP2, right? There's specific gene testing for that. One gene testing is going to be cheaper than a whole array of testing. Also, to remember, we're learning so much more, right? Rett syndrome and Rett presentation is not just due to MECP2. You have CDKL5, you have your FOX genes. All of these are now a spectrum of genes that present with Rett. So my takeaway home advice is don't be narrow in your differentials, learn in all the upcoming gene tests and see what is important in matching your patient's finances. You know, multi syndromes like Rett's, it's really important because it can affect the heart, right? There's a high risk of epilepsy. And so some syndromes really need that multidisciplinary care, whereas some others don't have effects on the heart as much. And if the parents can afford it and you are making sure they have a primary care physician that is checking all the systems, then we just have to support them with the financial resources that are available.
Sure. Yeah, the second question would be, what age will you be sure that child is now non-verbal? And what will you do when you find a non-verbal autism?
Yeah, so this is going to change over time, right? We can't just give up and say, hey, we're going to live for the next 20 years and not hope to make our nonverbal kids and not give them tools. There is research that shows that if verbal capacity has not been attained by 5 years of age, then the prognosis kind of decreases. But early intervention is powerful, but what do you do with the profound nonverbal kids, right? So there are other ways to enhance their communication. There is now Proloquy apps, there's picture apps. Some of my nonverbal kids, we start helping them with augmentative alternative communication. So that's something speech language pathologists should also be supporting families with.
Yeah, sure. And what are the neurotransmitters are underlying the self-injurious behavior in the child with ASD? And what
Okay.
pharmaceutical drug would you recommend in this kind of behavior?
Yes, this person should have taken a picture of my neurotransmitter table, right? So it's in there, the answer's in there. We know that the 2 FDA approved medications for dysregulation and autism is our Abilify and our Risperdal. They are mainly dopamine acting agents with some 5-HT supportive care. So hopefully in time, we'll have more meds to support them. And acting on
Yeah.
different variant neurotransmitters, right? Because that's the thing about being a physician for a spectrum that has multiple areas of maladaptive neurotransmission and connectivity, right? You can't just have a medicine affect one part of neurotransmitters. The winning agent is going to be an agent that targets different neurotransmitters in a symbiotic way for our future research.
And one question is addressing any role of DBS in the core symptoms of ASD? Deep brain stimulation, role of.
So there's not so much data for DBS, because what does DBS affect? I'm going to put you on the spot. It's good for, kids with some like dystonia stuff, right? It's good for maybe some kids with some epilepsy stuff, but even that's like debatable, right? DBS is most used in the adult world for Parkinsonism. But just like my slide said, we're not just talking about the basal gang, right? So that's a surgical intervention that's not going to just target more than one area of the brain, which is what is necessary for autism. We need to target a lot of areas. There's research that does transcranial stimulation, specifically targeting the cerebellum. I have some patients who are in those trials. And what we've seen is there's some temporary improvement in emotional lability and regulation, but it's temporary, at least in my patient population. I see it maybe last for 6 to 12 weeks, but then they come back to their baseline. It's like if I exercised a lot for 1 week and then I feel great, but then I'm still not going to be an Olympic player, So our job is to make sure we're not giving false promises to our families. We're making sure they're going to people that are well connected and have the right titles and the right research so that they're not falling victim to false promises and false therapies out there. Like hyperbaric oxygen therapy. We had a horrible case in the news where it even breaks my heart to say it, right? It creates a hyper flammable environment and the child burned to death. So it's really important to make sure when you're getting data that you're not making your child a guinea pig. It's a trusted institution with good ethical protocols for the research studies, and you're reading good scientific data.
I would like to
Sure.
add that for transcranial magnetic stimulation, we have done studies in the RCT. We have found we've made a theta burst protocol, and we have found that the behavior of these children is improves. But we are going to do another second study in which we'll be giving it periodically. So we have to see for how long it's going to last. That is something there. And I want it to be mentioned right now that there is no stem cell treatment ethically available right now, and it's only in research mode. Even we are doing exosomes derived from mesenchymal stem cells, but we're doing in ASD mice. So I think it should be only done in a in a research mode, so not in the clinical service mode as of now. The autism, because our stem cell is being exploited very much in our country. So I thought, because the question also, it should be like you mentioned about you had told me also the other day the child was burned to death about the hyperbaric oxygen chamber. So stem cell, I've had patient who had a stroke after the stem cell was given. So that's fair. Yeah. Any other question, Harsh? Then
Yeah.
any
What is
other
the role of
questions?
sulforaphane in autism?
So it's the same thing, right? We go in these circles because we're all trying to support these families, and some of these families are desperate because they love their child so much. So it comes back to what me and Dr. Gulati was saying, right? Ethical, research proven. There's good data that shows that there's improvement.
Evidence-based.
Yeah.
So we need your take-home messages now that you have to leave. Tuba, your take-home messages, and then I'll request Professor Paul and and Sejan and Professor Maya to continue for another 10 minutes for those next two cases. But Dr. Tuba, I know you have patients lined up, so can you please give your take-home messages?
Yeah.
And of course, you should welcome them to the AOCCN and the autism pre-conference workshop and the autism in the main thing. Yeah, but your
Yeah.
take-home messages.
I mean, the take-home message was in that last slide, right? We are
Yeah.
advocates at the end of the day. We have to support this family unit, this child, and we can just give in to, okay, now I've given you the diagnosis, that's it, you're on your own. We have to continue supporting them in this journey. And I feel so privileged to be surrounded by equal, passionate advocates. Thank you so much for having me. And I'm gonna say
you.
bye, and maybe I'll see you
Bye.
in September.
Yes,
Take care.
thank you. Bye. Thank you. Can you call the next cast please present?
Yeah. So Dr. Archana from Bangalore, India, can you present your case?
Archana, 5 + 2, please.
Yes, ma'am. Are my slides visible?
Yes, visible.
Okay.
You can make on a slideshow mode.
Yes, sir. Yeah. So, good evening, everyone. I'm Dr. Archana. I'm a pediatric neurology resident from Indira Gandhi Hospital, Bangalore. So, I'm presenting a 12-year-old girl. She's the first child of a non-consanguineously married couple. She came with history of recurrent episodes of paroxysmal events since 2 years of age. She had behavioral disturbances from 2 years of age and involuntary body movement since 3 years of age. So she had uneventful birth and development till 2 years of age. At 2 years of age, there was a triggering event. There was an episode of hot resin fell on her hand, and she had sustained superficial first-degree burns. And then she was managed on OPD basis. 3 days later, she had high-grade fever, followed by which she had the first episode of seizures, of GTCS type of seizures. So it was a GTCS kind of seizure lasting for more than 30 minutes with prolonged post-ictal drowsiness. She had multiple such episodes on the same day. She required PICU admissions, and she had poor sensorium with multiple seizures continuing. She required intubation and mechanical ventilation for a total 2 weeks and required multiple anti-seizure medicines because she had refractory seizures. Total ICU stay for around 1 month. By the time of discharge, she had lost all the developmental milestones which she had attained till then. She had no head control, no social smile, no fixing or following of objects, and there was no language milestones also. And then she progressively improved in the next 2 to 6 months. She slowly regained most of her milestones by the end of 6 months. But she continued to have recurrent seizures. So initially she had around 2 to 3 episodes per day for the initial 2 months after discharge. And then she continued to have around 1 to 2 episodes per month around similar frequency, but the duration was improving. She had a recent episode of epilepsy also, that was on 2nd of March. She had multiple semiology seizures. Few were focal seizures, few were right focal evolving to GTCS, and others were GTCS kind of seizures. And she had associated with that, she had behavioral issues which started around 6 to 8 months post the discharge, that is around 3 years of age. She had stereotypic movements like abnormal hand breathing movements, abnormal emotional dysregulation like aggression, emotional liability, and social disinhibition, ASD-like features, and few ADHD features also. These symptoms were persisting from around 3 years of age, and it is almost static till now. And she had involuntary movements like continuous writhing and jerky movements of bilateral upper and lower limbs, predominantly involving the distal part of the limbs, which started around 3 years of age, that is 1 year after the initial event. And the variability, and she had variable intensity of involuntary movements, which is pronounced during voluntary activity or during emotional stress. And it disappeared during sleep. And it was mild and not predominantly interfering with her motor tasks. All these symptoms are almost static throughout the last 10 years. And the mother feels that she is gradually improving over the years. There is no history of weakness of limbs, no hearing or visual disturbances, and no history of any cranial nerve involvement. And she had not lost any attained milestones after the recovery after 2 years of each. Her development was, she has global developmental delay. Her gross motor is finely normal, but she has delay in fine motor, social, language, and cognitive. So just a case summary, she had a normal development she had a normal birth history and normal development till 2 years of age. Followed by that, at 2 years of age, she had an acute febrile illness with encephalopathy, for which she required a prolonged hospital stay. Followed by that, she had a global neuroregression, and then partial recovery of milestones over around 1 year. But she persisted to have deficits like intellectual disability, cognitive more than motor. She had recurrent episode of seizures which are still persisting. She has behavioral issues and few extrapyramidal symptoms. Family history and the birth history was normal. So her treatment history, she required multiple anti-seizure medicines during PICU stay at the initial event. And then she was treated as ASD and ADHD over the last 10 years, requiring medicines like methamphetamine and risperidone. So it's a 12-year-old, so just a case summary, she's a 12-year-old female child, first born to a non-consanguineously married couple with unremarkable antenatal, perinatal, and neonatal history, with normal early development till 2 years of age. And then she after an episode of acute febrile encephalopathy, she had global developmental regression, followed by which she had lost all milestones, and then partial recovery over time. And she continued to have behavioral abnormalities, seizures, and involuntary movements, and which is remaining almost static over the last 10 years. So the initial diagnosis was intellectual disability, cognitive more than motor, with neuroregression following an acute episode of febrile encephalopathy, with epilepsy, behavioral issues, and extrapyramidal symptoms. The initial DDs considered were post-viral encephalitis sequelae like JE or other viral infections, autoimmune encephalitis sequelae, or some mitochondrial disease. On examination, her vitals were normal. Anthropometry showed her BMI was high and it was at risk for obesity. Her CNS examination, higher mental function, she was conscious, cooperative, oriented to place and person. She was right-handed. She had a small stance gait. Memory, immediate and recent were normal. She had a hypokinetic dysarthria, speech. Extrapyramidal symptoms like slowness of activities, involuntary jerky movement. This is a video.
Yeah.
So there are abnormal jerky movements and few stereotypic movements of her upper limbs which can be seen. The initial investigations were fairly normal. Both her CSF study and the other blood investigations were normal. Other investigations which were done over the years, she was extensively evaluated in outside hospitals. The Wilson's workup was negative. Genetic testing involving chromosomal microarray, Fragile X, karyotyping, and whole exome were normal, and whole exome was inconclusive. Other reports were that she had an EEG report at 2 years, 4 years, and 9 years, which showed multiple epileptiform discharges. She had total around 4 MRIs done. The initial MRI at 2 years of age, which was reported as normal, but on reevaluation, we felt that she had a few occipital lobe hyperintensities in flare sequences. The MRI at 4 and 9 years of age were reported to be normal. The last MRI at 11 years of age had shown mineralization of the
Can you please
bilateral.
expedite with? Can you please expedite?
Yes, ma'am. This is the abnormal EEG, ma'am, and this is the first MRI at 2 years of age, which are showing occipital lobe hyperintensities bilaterally. The MRI at 6 years and 9 years were fairly normal. The other investigations done was autoimmune encephalitis panel in CSF, which showed a positive NMDR, and OCDs were positive, which was showing type 2 pattern. So currently she has received 5 doses of injection methylprednisolone, and she's on her rituximab therapy. She has received 2 doses and she is about to receive her IVIG. So the final diagnosis was intellectual disability, cognitive more than motor, with neuroregression, following first episode of acute febrile illness, immune epilepsy with behavioral issues and extrapyramidal symptoms, and sequelae of anti-NMDR encephalitis. So
I think just
and
leave this. Yeah. Yeah. Take home message that can be summarized, can be done by Raju. Yeah. Raju, your message.
Yeah, yes, madam. This is so whenever considering this unusual features like ASD along with ADHD,
Stop sharing
visual
your
problem.
screen so that Raju can be seen on full screen. Stop
So
sharing.
whenever you see child with ASD, so with associated feature like ADHD, epilepsy, and extrapyramidal symptoms, you should always look for secondary causes and especially treatable causes like autoimmune encephalitis. Even though the disease onto very long, almost 1 decade, more than 1 decade, you should still find out the reason, exactly what reason, so you can get some proper specific diagnosis so that outcome will be good. Thank you.
Thank you. It's very important. And Harsh, we can have the last case and then we can have comments from experts for all the cases and they've taken message. Thank you. Thank you very, very presented a very important, relevant issue.
Yeah, sure. Dr. Anshia, can you come up with your case?
Yes, sir. I'm sharing my screen. Is my screen visible?
Yes, visible.
Okay. So, good evening all. I'm presenting a case of female child with microcephaly, autistic features and seizures from AIIMS Rishikesh under the guidance of Dr. Pratik Kumar Panda. So we have a 4-year-old girl, Miss A, resident of Saharanpur, under follow-up in OPD, who presented with the complaints of global developmental delay, seizures since 6 months of age, and autistic regression since 1.5 years of age. So the child had global developmental delay and excessive cry and irritability during early infancy, followed by polymorphic seizures in the form of epileptic spasm at 6 months of age, followed by left focal seizures at 1.5 years of age, and drop attacks around 3 years of age. It was also associated with autistic regression in the form of poor eye contact, poor social interaction, motor regression, gait instability, and certain stereotypic movements. The birth history was normal and the family history had no similar illness. On examination, the child had microcephaly, smooth filter, thin upper lip, broad nasal tip with no neurocutaneous markers and some dyskinetic movements. And the child had no purposeful hand movements. You can see in this video that the child is having orolingual dyskinesis or choreothetoid movements. Also, the child had typical midline stereotypic hand-wringing movements as well. So the social quotient by VSMS was around less than 25% with the CAR score suggestive of severe autism. However, it is confounded by underlying global developmental delay. So the differential diagnosis considered was Rett syndrome, as the child was a female with epilepsy, autistic regression, microcephaly, and midline stereotypies and disorganized breathing. Other differentials considered were CDKL5 related epileptic encephalopathy, as the child had epilepsy, global developmental delay, and some autistic features. Other differentials considered were creatine metabolism defects and GRIN related neurodevelopmental disorder. So on investigation, the MRI brain was done at 5 months of age, which is showing appropriate myelination with frontotemporal atrophy, with signal changes in pons and brainstem and corpus callosal thinning. By the time the EEG was done, the child was seizure-free and it was showing an organized background with no focal epileptiform abnormalities or any definitive discharges. However, occasional centrotemporal sharps can be seen. So we went ahead with clinical exome sequencing, which revealed a heterozygous frame shift insertion mutation in chromosome 14 of FOXG1 gene, resulting in FOXG1 syndrome. So the child was treated with valproate, levetiracetam, topiramate, and ABA, occupational therapy, speech therapy, and sensory integration therapy. Following which the child is symptomatically better and is currently seizure-free. So a few words about FOXG1. It's a transcriptional factor expressed in telencephalon, resulting in
Can you
dysregulation.
just come to the message, please?
Yes, ma'am. So the take-home messages in a girl presenting with global developmental delay, epilepsy, and autistic features and movement disorder, FOXG1 related disorder should be strongly considered. Thank you.
Yeah, Dr. Pratik, for your comment.
Sir, I wanted to present this case because this case had actually increased pubic hairs at this particular age. We initially suspected precocious puberty, and this is the first time I have saw precocious puberty in a child with FOXG1. It was a sensitive issue for the, actually we find out to be isolated adrenarche, FSH and LH were pre-pubertal. And so this was the one thing what I reviewed the literature. It showed that there were some case reports of precocious puberty in Rett syndrome, but for FOXG1, this isolated adrenarche, I think I have seen this for the first time. Parents were actually conscious, but we could not start leuprolide because it was only isolated adrenarche. We have asked them to come with DHEA levels. So I just want to know if the experts, they have any experience with precocious puberty in Rett syndrome.
Open to the experts. We can start. Professor Maya, Professor Paul Russell, Dr. Shenjan.
After, can I go ahead? Professor
Yes, sir,
Shefali?
please.
Yes,
Sir,
sir,
please,
yeah.
sir, please.
So after
Sir,
listening,
comment on all the three
yes,
cases and a take-home message. Sorry. Yeah, thanks for staying on.
I'll put all the three cases together. So it looks like there is so much of variation in the genetic makeup of the autism spectrum. There is also a very varied behavioral phenotype in autism, although we are restricting ourselves to the core three symptoms. So in the future, probably the genotype has to be kind of coupled with the behavioral phenotype, the trajectory of the various symptoms. Like we know in Prader-Willi, the child will eat more in the first 2 years. I mean, will not eat more in the first 2 years, then starts eating. So the behavioral trajectory clearly associated with the genotyping may be one way of we progressing in the clinical field of identifying and treating children with various forms of ASD. Thank you.
Thank you very much, Professor Paul. Dr. Maya? Dr. Maya, comment on the three cases.
Yeah, again, each of those cases, tells us very clearly, that the etiology can be very variable. One, tuberous sclerosis, another, possible NMDR. I'm just curious, you started the immunotherapy a decade later, Dr. Raju?
No, madam. Actually, they came to our institute recently, 2 weeks back only. So just now you are started. Okay, they are diagnosed. They are following somewhere else, multiple hospital. They came to their diagnosis just now only, man, few weeks back.
Okay.
So you are started with the IV methyl. There is some improvement. Definitely, there is significant improvement. You have noticed behavior and there is some improvement with it.
Sure. And finally, a FOXG1 related, autism, Rett phenotype. Sorry, I couldn't hear what Dr. Panda was trying to ask.
He was asking whether you have seen any precocious puberty along with FOXG1 in Rett.
Okay.
Any one of us, like I haven't seen any precocious puberty with Rett thus far. Although we had lots of patients, so I haven't seen. What about you?
Yeah. No, I too haven't seen. I've seen these FOXG1 presenting like an Angelman phenotype. Very happy, and of course they also have seizures. But perhaps they have some, endocrine endocrinopathies as well possible. Yeah, so like I mentioned, autism is one of the manifestations of a network problem of the CNS. So I think it's always important to evaluate each of them for a possible, especially a possible potentially treatable pathology. Thank you.
Thank you. Thank you so much, Professor Dr. Senji. Your take-home message and any comments on the cases.
I agree with Dr. Paul and Dr. Maya. Here in 3 cases, we see autism is a heterogeneous disorder with one hand with intellectual disability, and our case is high functioning, and several genetic disorders accompany with autism. Neurological and genetic investigation is important, I think. And that's all. I don't have any comment. Thank you.
Yeah, thank you. Thank you so much. Harsh, you want to say something? And Mahesh, Harsh and Mahesh?
Yeah, sure, ma'am. So it's a very enlightening talk from begin with, and a very nice case presentation and I think so. It's a very good learning opportunity. And I would like to advise, as ma'am has also told, it should be the family centric care in autism, which is the holistic foundation which lays upon. So each and every member of the family should be equally involved, and it's a journey from the diagnosis to entire holistic care to across the age span, and we have to witness that, and we have to be equally a care partner in that journey. Yeah, thank you.
Thank you, Mahesh.
Ma'am, nothing to add, ma'am. We've had a very wonderful cases and a wonderful discussion, ma'am. Thank you.
Raju and Pratik, you want to add anything?
Thank you, ma'am.
Nothing, madam. That's
Yeah, thanks. I think we have to remember the word autism spectrum disorder. That spectrum says it all. So we are all going on saying it is there in the term. It's now autism spectrum disorder. So spectrum meaning that if it's diverse and every child is going to be different, and we have to as professionals try to handle them and guide the family forward. And I think it's not that we are going to be, as pediatric neurologists or psychiatrists, look at the focus thing. You have to look at the entire family, not even say the entire child. So I think that is what it is there. And again, we all thank you so much for joining, and we invite you to the 17th Asian Oceanian Child Neurology Congress in New Delhi and Yashabhumi. We welcome you all. And I say, as I mentioned, autism is one of the pre-conference workshops. There are 8 pre-conference workshops, and we'll have lots of academics. So I think we welcome you all, and I think Asmita, you can put the video in the end, and we meet again next week. Actually, we'll be having a next section next week, so we get back next week. Thank you so much, Professor Paul and Professor Maya and Dr. Shenson for joining and staying so late. Thanks.
Thank you so much. Thank you.
Thank you. Thank you.
Thank you. Good night.
Thank you and good night.
and everybody else would gather together and come up produce a solution.
Thank you. Good night.
Okay.
Thanks. Bye.
Good night, ma'am. Good night. Good night.
Bye.
Thank you.
Good night. Good night.
Good night.